The following equipment to perform the procedure: surgical chest tube, antimicrobial scrub, scalpel, forceps, Kelly clamp, sutures, needle driver, suction source, chest tube collection device, male-to-male connector, shoulder roll, monitoring equipment.
The nipple signifies roughly the fourth interthoracic space, at which point the chest tube is then placed in the anterior axillary line, just lateral to the nipple, but at the same level, to ensure that the chest tube is not placed too low in the anterior axillary line on the affected side. We then make an incision below the affected rib space. The incision needs to be large enough not only to accept the chest tube, but also to accept the clamp for the dissection into the chest cavity itself. The incision is made with any sharp knife that is then placed off the field so as not to inadvertently injure the operator or the assistants. You then take the blunt instrument, you then find your affected rib space, you then gently dissect in directly over the rib cephalad to where you are, thereby confirming the location. You then dissect into the pleural space. Once you have adequate entrance into the pleural space, the clamp is left in as a bookmark, if you would, to guide the passage of the chest tube, which is then placed through the clamp itself and then into the patient. Sometimes the chest tube will be assisted by placing the clamp around the tube to help guide it through the ribs and into the pleural space. Once the chest tube has been adequately placed, it then needs to be secured in a proper position with the placement of a suture in and around the chest tube itself. The chest tube may be secured in many different ways. We attempt to perform a single Roman stitch, whereby we tie it down to the skin first, locking it in place on the skin, and then having the suture go in and around the tube itself to then secure it to the skin stitch. Sometimes more than one suture is needed to perform this technique.
An occlusive dressing is then placed over the site of chest tube insertion.
Once the tube has been placed in the proper location and secured in place, we then take a male-to-male connector so that we can connect the chest tube output to our collection device to collect both air and blood. Once the tubes have been placed via the connector, the tube is then
extraction device, the chest tube can be removed. Complications. The complications that you may observe include injury to lungs, heart, liver, other organs and soft tissues, bleeding, pneumothorax, infection. Assessment and monitoring. First of all, it is important to monitor the patient's vital signs, including oxygen saturation. You will also want to monitor how much, if any, air, fluid, or blood was removed during the procedure. Lastly, you will want to assess the patient's comfort before, during, and after the procedure. Documentation. Following chest tube placement, you should document the following information in the patient's medical record. Indication for procedure. Date and time. Size and site of chest tube placement. Amount and type of drainage removed. Confirmation of placement on chest X-ray. Adverse outcomes.